welcome to the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley. I'll be your host tonight. I am TMA Senior Manager of Education, Support, and Advocacy. Today, we have the honor of speaking with Dr. Tahseen Mozaffar. Dr. Mozaffar is a professor of neurology and pathology and laboratory medicine and the vice chair for research in the Department of Neurology at University of California, Irvine. Dr. Mozaffar is also the director of the UC Irvine MDA, ALS, and Neuromuscular Center and the director of the UC Irvine Neuromuscular Program. He is a member of the Medical Advisory Board for TMA and serves as the MAB liaison to the board at TMA. Dr. Mozaffar's immunological research interests include characterization of the myopathology and various forms of immune myopathies, including the first description of myopathology and Jo-1 antibody-associated myositis. Based on his seminal work, this form of immune myopathy has now been given a separate classification of antisynthetase syndrome. His most recent work has been in various subtypes of dermatomyositis, immune-mediated necrotizing myopathy, and in collaboration with Professor S. Armando Valata, a deep phenotyping of the immune infiltrates in sporadic inclusion body myositis. And that was a mouthful of a biography. Dr. Mozaffar, welcome, and thank you for being here.
Thank you, Rachel. It's a real pleasure. And I think I've spoken to this group on a few occasions, so hopefully they're familiar with some of the work and some of my style. And I want to apologize up front if any of you have a diagnosis of polymyositis, because I don't believe in polymyositis. So we will probably have a healthy discussion on what other diseases you may have on that. But what I wanted to do was to spend 10 minutes just going over some of our recent work, and especially to highlight this ongoing natural history study that was funded by the National Institutes of Health. They started in April, and we still have sites that are coming online. So there may be an opportunity for some of you to participate in that. So this study is called Inspire IBM. It is a multi-center observational study in inclusion body myositis. And the reason I use the word sporadic, even though I'm not a big fan of that word, is just to make sure that you guys understand that there are other forms of inclusion body myopathy that look like IBM, but may have a genetic underpinning to it. So part of this is to truly differentiate it from sporadic or inflammatory or spontaneously occurring inclusion body myositis. Now, our understanding of the pathophysiology of immune myositis now is that the initial dysfunction in IBM is an inflammatory dysfunction. So there are these persistent, highly differentiated lymphocytes that may be causing some of the initial damage. They are attacking muscles, and these muscles express MHC class 1. That attracts these cells to these muscles. There's also a very strong interferon signal. Interferon is one of the mediators of inflammation. And what then happens is that there is a progressive dysfunction in the mechanism of cell function. So the inflammation in itself causes stress on the cells. It causes a dysfunction of the mitochondria, which is the power generating cells. And all of these then result in dysfunction of the proteasome, which is a organelle within the cell that handles protein and excessive proteins. As a result, you get this insoluble amount of protein that keeps building in the muscle, and it results in autophagic dysfunction. So this is how we feel about the disease. As I said, the initial insult may be an inflammatory insult, and there are a whole variety of immune abnormalities that have been reported in IBM. Ultimately, it results in a cell dysfunction by interrupting the normal functioning of the cell, by whether it's the endoplasmic reticulum stress, whether it's protein aggregation, whether it's dysfunction in autophagy, formation of vacuoles, which then results in myofiber necrosis and myofiber regeneration, or defects in regeneration. So again, as the disease progresses, the amount of inflammation reduces, but the amount of the degeneration of the muscle increases. And there's always been this debate which came first, which is whether the inflammation came first, whether the degeneration came first. For the longest time, people have focused on degeneration as being the primary mechanism. And part of that was because none of the conventional drugs worked on the inflammation side. But now there is very strong evidence that the inflammation may still be relevant. It's just that it's a different type of inflammation, and that's why it has not responded to treatment. So based on this, and immediately following Dr. Greenberg's discovery of the specific antibodies in IBM, my group published a paper that suggested for the first time that the presence of antibody in IBM may predict a more severe disease, especially in terms of muscle involvement of the throat muscles and the respiratory muscle. So this paper was published for the first time online in 2015, but came out in print in 2016. Dr. Namita Goyal, who's a member of the Medical Advisory Board, was the first author on this paper. And what we showed was that if you looked at time get-up, which is a good function of proximal hip muscle strength, was significantly reduced in patients who are antibody positive as compared to patients who did not have the antibody. If you looked at their lung capacity measured by forced vital capacity, again, it was significantly lower in patients who were antibody positive versus those who were antibody negative. And then patients who were antibody positive definitely required a lot more assistance in terms of ambulation. So majority of the patients in the antibody positive group required either a walker or a wheelchair, whereas none of the patient in the patient group that did not have the antibodies required these equipment. And then there was a higher incidence of swallowing abnormality in patients who were antibody positive. There was a confirmation of our work from the large European study run by James Lilleker. And what James was able to show that a lot of the things that we said in our paper were true, but he also showed that if you look at long-term life expectancy, then patients with antibody positive IBM on an average live about 8 years less than patients who are antibody negative. I mean, it's 8 years of a life expectancy of 70 plus years. So it's not like they're dying young, but if you compare within the group, there was a difference in terms of life expectancy. Now, a recent work by Dr. Chris Weil, another member of our medical advisory board, did not support that idea. But when we looked at the patients that we contributed from UC Irvine into that large cohort that Dr. Weil was analyzing, that still held true for UCI patients. And I don't know what the reason for that is, because maybe we don't take as good care of a patient. I'm just joking. But our patients, at least who are antibody positive, did not had a lower life expectancy on that. And then there was a very nice Japanese study run by Dr. Tawara, who's currently doing his research in France. But he showed that if you take blood from patients who have the antibody in their blood, compared to patients who did not have antibodies in their blood, there was a marked difference in what happens to the animals if you pass this blood on to animals, or there was a huge difference if you put that blood in cultures of muscle cells that are growing. They get these abnormalities of these inclusions that are only seen with patients in whom the blood had the antibodies and not seen in patients who did not have the antibodies. So again, suggesting for the first time that the antibodies and the inflammation may be driving the degeneration rather than the degeneration driving the antibodies, which had become the generally held notion in IBM. So based on this, and we felt that there is a need for a natural history study in IBM, and the lack of a natural history. We don't know how the disease behaves in the long term. If you follow a patient for a year, 2 year, 3 year, are they going to show changes that are quantifiable? Are these changes going to vary depending on whether they have the antibody or not? Are they going to vary based on the inflammatory cells that Dr. Greenberg had described, these variant T cell population? And none of the studies that existed in the literature really followed patients for more than 1 year in a systematic, organized way. So we felt there was a huge need for a prospective natural history study in IBM, and then we therefore applied to the NIH for such funding so we can run a study like that. Before we did that, we surveyed about 2,000 IBM patients through the Myositis Association, and some of you may have participated in the study. And what we really wanted to know was whether because this natural history study does not have a treatment arm, we are not providing any intervention, would IBM patients even be interested in participating in such a study, especially if it goes on for 2 years and it requires frequent visits to the clinic, and if it requires invasive procedures such as muscle biopsy. And to our surprise, about 500 people responded to it, which is still a reasonably good number. And majority of the patients were very enthusiastic about participating in such a study, including the fact they were willing to do a muscle biopsy. Just to compare it, we sampled a similar number of patients in Australia through Professor Needham's group in Western Australia, and we got very similar information. In fact, the Australian patients were a little bit more enthusiastic than maybe the American patients, especially when it came to frequent blood collections or muscle collections. To further increase our knowledge, we took advantage of this mechanism called Community Engagement Studio, which is a NIH-funded mechanism where you put a bunch of stakeholders, in this case, these are IBM patients and their caregivers, in a room where they are asked specific questions by a moderator. In this case, this was Dr. Olshansky, who was a former dean of our nursing school. I sat in the background as a silent participant, and we took notes. And we got some really helpful information from the patient community on what's the biggest need from a patient perspective in terms of IBM. Things that we would have never thought of that, which, like, instance, pain. Pain is a big issue in IBM, but most clinical studies don't address that. There are other issues such as respiratory function or sexual needs, etc. So based on this input, we were actually able to incorporate some of these elements into the study. And it was both the patient survey as well as the community engagement studio was very well liked by the grant reviewers at the NIH. And one of the reasons why our grant was successful, because they really liked this innovation in our grant. So ultimately it got funded. It is a 4-aim study. The first aim is to look at whether the presence of the anti-5C1A antibodies influence disease progression and disease behavior. Aim 3 was to also look at the lymphocytes, or these inflammatory cells in the muscle as well as in the blood, and see if they influence the disease phenotype or disease behavior in any way. We thought this was a great opportunity to look at a detailed analysis of muscle tissue from patients with IBM, and it required taking a fresh piece of muscle. So we're only doing this in about 40 of the 150 patients. And then that gave us an opportunity to look at respiratory functions, pain, sleep, and other functions for the first time in a detailed, systematic fashion. So there are a whole bunch of hypotheses. We think that patients who have antibody will progress faster compared to patients who are antibody negative. These are the schedule of visits. There are 5 visits for each patient. So they'll be done at baseline, 6 months, 12 months, 18 months, and 24 months. And these are all the measurements we're taking. We're doing a detailed assessment of their muscle strength, using both manual testing as well as handheld dynamometry. We're doing functional assessment using IBM FRS, which is the standard functional rating scale, time get up and go, which evaluates their proximal functions, a pegboard that uses the hand dexterity functions, fall assessment as well as mobility assessments. And then we are using swallowing evaluations, a whole bunch of patient-reported outcomes, especially pain, depression, sleep disturbance, quality of life. And then we're looking at physical exam, neurological exam, and looking at blood for lymphocytes as well as antibody. We're also looking at muscle biopsy, as I mentioned, specifically looking for these CD57 positive cells as well as KLRG1 positive cells. So we want to see if there's a difference between patients who are antibody positive versus antibody negative in terms of muscle pathology. And these are all the muscles are going to be sent to UC Irvine. It's going to be evaluated in a standard fashion and then compared to their blood abnormalities. So we're collecting blood at the same time as the muscle biopsy. So we should be able to figure out what the blood reflects as opposed to the muscle reflects in terms of inflammation. Again, we're looking at these lymphocytes, the abnormal atypical lymphocytes. This is some of the data that we recently collected on what's called a deep phenotype. A deep phenotype is just doing in detail subtypes of different inflammatory cells. And what we were able to show that these are highly differentiated lymphocytes. These are lymphocytes that have been chronically overstimulated. They have sort of lost their opportunity or ability to undergo apoptosis, which is cell death. And that may be the reason why they do not respond to conventional immunosuppressive therapy. And there seems to be much more increased in IBM patient compared to normal age-matched population as well. And then finally, we're going to look at respiratory functions and sleep disordered breathing in patients with IBM because we believe that is an important contributor to their disease morbidity and mortality. We have some preliminary data from our clinic showing that there is a progressive decline in respiratory function in the antibody positive patient, but not so much in antibody negative patient. So again, trying to prove all of this. We did a very detailed calculation for how many patients we would need, and in the end came up with enough power to have meaningful determination from the study, and we decided we're going to take 150 subjects. Just the way the antibodies are distributed, about 100 of these are going to be antibody positive, and 50 of them are going to be antibody negative, and that will give us enough statistical power to make meaningful determinations on that. There are 13 sites distributed throughout the country. The only obvious omission is the Southeast or the Florida region or Georgia region. We might be adding a Florida site depending on how the other study sites perform, but right now we haven't made a decision on that. So there are 2 sites in California, there's a site in Oregon, there's a site in Washington, there's a site in Colorado, 1 in Kansas, 1 in Missouri, 1 in Ohio. There's Johns Hopkins is a site in Maryland. We have University of Pennsylvania, and we have a site in Brigham Hospital in Boston, and then 2 sites in Texas, 1 in Dallas, 1 in Houston. These are the site PIs. So again, I'm the overall coordinator of the study. I oversee the entire study, but the day-to-day evaluations are done at these various sites by people who are very experienced with IBM. They're the experts at it. And then there is a whole village that supports the study. So there is a steering committee that looks at these results. We decide what to change, what not to change, what's working, what's not working. The Muscle Study Group Coordination Center at Rochester in New York is the data coordination site. And then we have a full-time statistician, and we have a full-time immunologist, Dr. Vialta, who's doing all the analyses. Dr. Marie Perez Rosenthal will be looking at all the muscle pathology. It is funded. The first patient was enrolled in October of 2021, so we missed it by about a month. We now have pretty much all the sites up and running. I think the only one left now is Brigham in Boston, but Johns Hopkins just went online. I think Pennsylvania is going to be next. So Penn and Brigham are the only two sites left at this point that have not started taking patients on that. The actual study runs for about 2 years, and then we have given ourselves about 2 years to finalize all the data analysis on the data and the publications, etc. on that. One of the good things that's going to come out of this study is that there will be a large repository of very detailed patient data matched with blood samples, DNA samples, RNA samples, and muscle tissue, which can aid further research and future research in ALS. We already have a whole bunch of very fancy studies planned that were above and beyond the scope of this grant. So we are working with other academic groups as well as industry partners to do some very sophisticated single cell level analyses on these tissues, including very high resolution mass imaging platform as well as RNA sequencing platform. So a lot of good will come out of this study irrespective of what the data shows at this point. And then there are future opportunities. So there are other opportunities that we can utilize in terms of grant funding to do secondary analysis of things that we did not put or did not have the opportunity to put in the first grant. So I'm going to stop here. And then some exciting things are happening at UC Irvine. We have a new hospital coming up, as well as an entire research building that has 200,000 square feet of research space, and that will really benefit myositis research. We've just created a muscle institute at Irvine and growing it. So I'm happy to take any questions. I believe we were sent some questions, and Rachel has volunteered to read it out. And then if time is left, then we will take some of the questions that were in the chat. But before we do that, I'm going to answer Martha Arnold's question, because I think she asked a very important question, which is if 24 months is going to be enough. And that, unfortunately, is the nature of the granting mechanism. I mean, we can potentially have done 3-year study or 4-year study. The risk with that is, one, most funding agencies will not want to fund a study that long. And the other risk is patients lose interest and you have a much higher dropout rate in a 4-year study or a 3-year study, especially if you're not doing any intervention. So we felt that 24 months was just good enough, long enough to give us useful information. We were originally going to do 3 time points. We added the number of time points to 5, so we have more data. And hopefully all of that will give us very good information to design future studies and future interventions. Rachel, do you
All
want
right, thank you. Yes, do you mind to stop sharing your screen?
Yeah.
And then we will move forward. One of the questions that was submitted, can you build muscle with IBM?
So, and that is the hope. So the biggest challenge right now, and that's one of the reasons why the bimagrumab study, the resilience study, failed, was that I think myostatin inhibitors or any of these muscle growth factors work best in normal, healthy muscle. So a lot of these data on muscle building come from healthy individuals or people who are bodybuilders or exercise folks. What happens to disease muscle, we don't know. So it's possible that the drug works, but because we haven't stopped the disease progression, you nullify the effect of the drug. So the ideal combination would be that, let's say if a future treatment works and it slows down the disease progression or it stops the disease progression, and you combine it with a muscle builder, that the ideal combination would be to do both of them at the same time. So that's why we have not completely given up on a drug like bimagrumab. Regeneron, which is based in New York, also has a similar drug that they were originally going to do a trial in IBM, but then they decided to hold back. But let's say if the ongoing treatment trials such as rapamycin or the Apcuro drug shows promise in terms of stopping disease, we can potentially combine it with bimagrumab or similar drug to then build the muscle, because now the disease process has slowed down or stopped and we can increase muscle growth.
Great, thank you. Another question, is electrical stimulation of muscles effective?
So I'm again, the same issue applies here. So muscle stimulation works best if you have a chance of, if you have no disease and you have a chance of coming back. So for instance, if somebody has a fracture and they have been placed in a cast and they're immobilized, the muscle underlying that is normal, but it's undergoing atrophy because you're not using it. That's where electrical stimulation works best, because what you're doing is you're faking the muscle to think that it still has ongoing activity and it maintains its size. Or let's say in a nerve injury, somebody has a fracture, the nerve got stunned and the nerve is not functioning temporarily, but it has the potential to come back to full functioning at some point. Then electrical stimulation is great because you can then bridge that gap and you can keep the muscles active while the nerve is waiting to recover. But in a disease, one, it's in an intrinsic disease of the muscle, such as IBM, I'm not sure that electrical stimulation would necessarily work because one, it's we don't know if it works in non-nerve diseases, and number two, the disease is still ongoing. You haven't stopped the disease. So similar to what happened with Bumagumab, even if it works, it's going to be negated or nullified by the fact that the disease is progressing.
Is there any evidence that the symptoms of IBM can be reduced with infrared therapy, supplements, or changes in diet?
At this point, none. I mean, I'm not even sure what infrared therapy does. So there's no scientific basis to support that infrared therapy would necessarily help. Some people swear by creatine as a supplement. Again, creatine has primarily been studied in healthy individuals who do weightlifting or athletes. Whether it works in individuals who have diseased muscle, we don't know, but it's a fairly harmless supplement, and I fairly routinely prescribe or at least recommend that patients take creatine without any clear data to support that it works. Some patients take anabolic steroids, which is dangerous, but there are milder versions that have been shown to work in muscular dystrophy. So, not in IBM, but in other forms of inherited muscle disorders. Occasionally I would prescribe oxandrin, which is the mildest of the anabolic steroids, but I would not recommend that in IBM only because majority of the patients with IBM are males, and anabolic steroids increase the risk of blood clots as well as prostate cancer. So that's not something that I would recommend willy-nilly in IBM.
Okay. What appropriate therapies are there for IBM patients with weakening hands and wrists?
So, I mean, we recommend occupational therapy because they can teach you strategies to improve your hand function or at least compensate for your hand function. Dr. Tom Brouchard at Johns Hopkins has been evaluating surgery of the hand to improve function. He hasn't published that data yet, but I know he's presented it at a few of the myositis meetings. And there's a similar interest. Dr. Salman Bhai, who's at UT Southwestern, and he and one of his old colleagues from Brigham Hospital in Boston are also looking at using hand surgery to improve hand function. But again, this is relatively infant knowledge. We don't know enough about the long-term safety or the long-term benefits.
Why would someone with IBM have low fasting ESR levels?
Again, ESR doesn't mean anything in IBM. I mean, IBM, even though it's an inflammatory disorder, usually has no relation to ESR. The ESR can vary because of a variety of reasons. If somebody has low ESR, is actually good. It's not bad. But a lot of factors go into ESR. People who have low protein levels can have low ESR. If you have a lot of muscle wasting, your ESR can be low. So depending on what the factors are, they may have low ESR. But like I said, in general, you want your ESR to be low. You don't want your ESR to be high.
How does IBM affect the throat muscles? Does it create excess saliva, especially in sleep?
So it causes problems with swallowing, right? So you're not able to swallow food effectively. There is always a risk that it might be going into your airways. It also, people who have swallowing difficulty or throat muscle weakness are at higher risk for sleep apnea. So that's the other problem that happens with it. And you need to swallow your own secretion. So the saliva that you produce, you're supposed to swallow it to get rid of it. So patients generally who have impaired swallowing tend to have more saliva in their mouth. So they may drool at night, especially. So that those are some of the challenges that we see, not so much in early IBM, but in really advanced IBM patients who have very severe swallowing issue or facial weakness. We sometimes see that.
Is anyone studying metformin for use with polymyositis? The disease you don't believe exists.
So the disease that I don't believe in. And again, just to clarify that, I think polymyositis is overdiagnosed. Majority of the patients who've been diagnosed with polymyositis probably either have IBM or have necrotizing myopathy. They don't have polymyositis, and the incidence of polymyositis is probably less than 2%, even if that's high. So it doesn't make any sense to use it in polymyositis, but it does make sense to use it in IBM, because one of the effects of metformin, similar to what has been being studied in rapamycin, is that it improves autophagy. So that's why I know Dr. Weil has been studying this for a while, and he's the one who first suggested this idea, at least to me, that there may be a potential for use in metformin. Challenges with metformin is that one has very severe GI side effects. It can cause weight loss, and it can cause low blood sugar. So you have to be careful using a drug like that. I mean, and not to say that I have not used it in 1 or 2 patients, but it's not a drug that I'm routinely using in IBM patients.
Yeah. Please discuss the interaction between IBM and neuropathy and give any advice on dealing with this affliction.
Yeah, and that's a great question. So neuropathy is commonly seen in IBM. Okay. Now, what's the difficult part is we cannot confirm the association of myopathy and neuropathy together. It's not that IBM is causing the neuropathy. It may be an age-related effect. So the data is very simple. About 5% of the US population above the age of 70 have a neuropathy. Okay, that's also the population that gets IBM. Okay, so it may be true and true unrelated that patients with IBM also happen to have a neuropathy, which is just an age-related phenomenon. Okay, but it is a common association. I would say about 40% of IBM patients have some form of neuropathy. Almost never disabling from a neuropathy point of view. Some of them may have some numbness and tingling, which becomes a nuisance more than anything else, but not a major contributor to the disease.
If the initial results from the trial of Alcuro's ABC008 hold true for all IBM patients, will this be the cure to stop progression of IBM? What additional obstacles does that drug need to overcome?
Well, means first of all, they have to show that the drug is safe, and that's the purpose of doing this phase 1 study. So when you go through stages of clinical development of a drug, first you have to use it in normal individuals. Then you use it in patients with IBM to show that it's not going to make their IBM worse. And that's the study that's undergoing right now in Australia with Dr. Needham's group, to show that one, it's safe, and number two, it's not making their IBM worse. Once that, and then it also allows us to figure out what doses are effective, what doses are not effective in terms of actually reducing the amount of KLRG1 cells. And those are the doses they will then use in phase 2 study. And then ultimately there will be a phase 3 study, which is going to be what's called a pivotal study. The good news is, because IBM is a rare condition, all you need is one well-designed phase 3 study to seek approval from the FDA if the drug works. Okay, but we are a little bit further away from that. Cure is always a strong word. I don't like using the word cure. I think treatment is a better word. If it can significantly deplete the amount of KLRG cells, and presuming that KLRG cells is what's causing the disease progression, if you can stop the disease progression, that's a major miracle. I mean, we all are praying for that. We all are hoping for that. But life is not always simple. So sometimes, despite our best effort, the drug doesn't work.
It's true. Can you offer any insight on the relationship between cytotoxic T cells and a virus? Does their presence in IBM tissue show that a virus is a likely cause?
So again, that's a question that has not been answered. So as if you remember the history of IBM, the IBM originally was described as having changes that were seen also with mumps virus and other viruses. So if you look at the first 10 years of inclusion body myositis, starting from 1968, when Dr. Chow described it in muscle pathology samples up to 1978, the impression was that this was some kind of a indwelling, it's some kind of viral infection that keeps going on. Now, with time, that has been put to rest. We don't think that's the case. But recently, I mean, all we can say is that these KLRG cells or these highly differentiated T cells are probably overstimulated cells. So they are seeing some antigen, they're seeing some infection or in low-grade inflammation on a regular basis that has led to exhaustion of these cells. And so they've lost their characteristics to undergo cell death. But it's all because of chronic overstimulation from some antigenic source. Whether it's an infection, whether it's a low-grade inflammation, we don't know the answer to. Rachel, I'm going to step out for just a second. I need to grab something.
Of course. While he steps out, I'm going to take a look in our Q&A to see the questions that have come up.
Sorry, since I'm in isolation, I'm dependent on my wife to bring me my tea. So I could not disappoint her.
Self-care is important. All right, let's see. Is it possible to have both DM and IBM together? I have DM, my lab test for IBM showed a positive reading for IBM. However, I also have Sjogren's and read that if you have Sjogren's, you can test positive for IBM, even if your rheumatologist does not think you actually have IBM.
Again, that's a little bit more complicated. So first of all, you're not supposed to have two diseases of the same type. So either you have DM or you have IBM.
Okay.
Now, there is a strong association of Sjogren's with IBM. About 15% of patients with IBM have a history of Sjogren's. And we know that the anti-5C1A antibodies can be seen in patients with Sjogren's. Now, some of them do not have muscle weakness. Okay. Generally, if you have muscle weakness and you have the antibody, then you have IBM. Okay. So depending on the age, if the individual is more than the age of 45, if they have the anti-5C1A antibody and they have weakness, they are more likely to have IBM than DM. DM has skin rash in majority of the cases.
Has there recently been a link established between IBM and a particular form of leukemia?
Yes, so based on Dr. Greenberg's original paper, he thought that up to 50% of patients with IBM may have this form of leukemia called T large cell granuloma leukemia, TGL. We looked for it in majority of our IBM patients, and we are not finding that high of an incidence. Yes, about maybe 10 to 20% of patients will meet the criteria for TGL, but TGL, like these lymphocytes that we see in IBM, are essentially a manifestation of overstimulation. Most oncologists would not even treat that form of leukemia, even if they diagnose the patient with leukemia. So at this point, it's not really clear whether TGL behaves like a true cancer or true leukemia. It may be just a manifestation of something similar to what we are seeing in muscle and blood, where you see these highly differentiated, overstimulated lymphocytes, but they in itself are not malignant and they're not cancerous as most other cancers are.
Does IBM affect the heart and lungs?
It does not affect the heart. It may affect the lungs in advanced stages. So the respiratory functions may be impaired. The reason it's difficult to pick it up is most patients are ambulating less than usual, so they don't complain of shortness of breath. But if you objectively look for data, there is evidence for dysfunction in about 1/3 of the patients.
Okay, I am going to move into our Q&A. If a person is diagnosed with SIBM with a muscle biopsy and a negative antibody, can they convert to being antibody positive?
That's a great question. And we don't know the answer to that simply. So that's one of the things that we want to study in our natural history study. And that's why we are doing 3 time points for the antibody. So we will do antibodies at baseline, we'll do antibodies at year 1, and we'll do antibodies at year 3. And one of the questions that we want to answer is, does somebody who's antibody negative convert to antibody positive state? And similarly, patients who are antibody positive, do they ever convert back to normal on that? I know that in Dr. Weil's paper that was published in the Annals of Clinical and Translational Neurology, he had a few patients that did turn positive after a year or two. Okay, but the true incidence is not very well known.
Is NT5C1A antibody the same as 5NT1A?
Yeah, and then some people call it C1A. So there are all sorts of names, but the original name was NT5C1A, and they've shortened it to C1A antibodies. 5NT1A is probably just a misinterpretation of the actual name.
Okay. How quickly would sirolimus become available if the phase 3 trial is successful?
So sirolimus has been around since the 1980s. It's available by prescription, but it's mainly used in the context of organ transplant. So right now it's mainly used in patients who've had kidney transplant or liver transplant. Your physician potentially can write it as a prescription, not that I would recommend it, because you have to do a lot of monitoring. So again, if that study that Professor Needham has started on rapamycin, if it shows promise, your physicians can start writing for it because it's already an approved medication, and you will have a phase 3 study to show that it worked. Okay, so we don't have, at least in this case, we won't have to wait for the drug to get FDA approval because it's already FDA approved for another reason, but it's available on the market.
Is there any known association between IIM, IBM, or non-IBM and proteinuria? If it does it change the management?
So there are cases of proteinuria associated with dermatomyositis. I'm not familiar with proteinuria in the context of IBM. And again, remember, a number of cases of proteinuria are related to inflammation in the kidney. So some patients who have inflammation in the muscle may at the same time also have inflammation in the kidney. But there is no such relationship, to my knowledge, in IBM.
Okay, we have a supplement question. Would you advise against the use of zinc and elderberry in IBMers?
I generally am very cautious about using zinc, and I'll tell you why. So zinc has become a fad. Actually, my wife put a bottle of zinc on my bedside table for my COVID infection, which I did not take. And the reason for that is zinc competes with copper for absorption. And if you take zinc supplement on a regular basis for dubious reasons, because I'm not convinced that it necessarily is the greatest anti-inflammatory, you will have low levels of copper, which are far more dangerous than that. So zinc is also in denture creams. So a lot of elderly folks are using denture creams, and that has zinc in it as well. So you have to be careful. If you are taking zinc, you probably should also take copper, and you at the least should monitor for copper levels if you're taking zinc supplements on a regular basis. But the idea that somehow it is the best drug to reduce inflammation is just not there.
What is your best advice to the IBM patient who is trying to retain quality of life and physical functionality?
So I would say one, be positive, because again, there are a lot of smart people who are working to find cures for it and treatments for it. Number two, you need to attend a clinic and a neurologist who can help you cope with that disability. Because again, there are many different ways we can continue the quality of life by using adaptive devices, etc., and simple therapies that will improve. So if you have access to a local muscular dystrophy clinic, and remember, IBM is one of the muscular dystrophy covered diseases. You can be one of Jerry Lewis's kids. I know. So that's something that I would recommend. You need to see a physical therapist, because there are things that we can do to help you have a better quality of life.
Someone anonymous asked, is dizziness common in IBM?
Dizziness is not necessarily common, and if they are getting dizzy, it's probably some other age-related cause that they should get their primary care to investigate. Rachel, I'm seeing questions about KLRG cells, so let me answer that question.
Okay, great.
So KLRG cells are the subset of highly differentiated memory T cells. So the T cells, which are one of the inflammatory and infection fighting cells in our body, comes in all shapes and sizes. And the ultimate stage in progression, so you can start from naive T cells to memory T cells. And then the latest stage of that is they call terminally differentiated T cells, which are cells which are at the end of their life. They've been around the block. They've seen a lot of infection, and these are the cells that typically express this protein on their surface called KLRG1, and that's the one that Dr. Steve Greenberg described about a few years ago. And that's the one that's going to be the target of the treatment that is being proposed by AppCuro, which is going to be running a clinical trial later this year on trying to deplete the body of cells that express KLRG1. So it's an important term to remember. You probably would want to know what your KLRG status is, which can be done on flow cytometry. And it's something that is potentially targetable in terms of drug treatment. So there will be a drug treatment on it.
When you talk about overstimulation of T cells, lymphocytes, is stress a factor, or are there other factors that might impact overstimulation of T cells?
I think generally it means that these cells have seen either infection or inflammation. I'm not sure that stress in itself can overstimulate them, but it generally means that there's a low source of infection or inflammation that these cells have encountered, and they have gotten stimulated because of that.
Is a possible cause or contributor of IBM to have old virus fragments in the muscle, and could antiviral meds possibly be a treatment?
At this point, there's no evidence that antiviral will do anything. I mean, again, I'm not sure that we have completely ruled out the virus, but that is no longer the most popular hypothesis.
Okay, let's go back to, if you have any further questions, please put them in the Q&A, and then
there was a question on what drugs are in trial right now.
Okay.
So right now there are two active studies to think about. One is the rapamycin study. And as you know, the initial funding only provided for 2 US sites, which was Kansas and Johns Hopkins. Now the Kansas group has applied to a federal grant. If that gets funded, then they will add 2 more sites in the US. One of the sites will be in Irvine, where I am, but the other sites, I don't remember what the other site is. But there will be 4 sites in that case if that grant gets funded. So You can put pressure on your congressman or congresswoman, or you can pray, whichever works best, that grant gets funded so we can add more sites to it. The second study is going to be on the KLRG1 depletion, which AppCuro, which is a company based out of Boston, is going to be doing. And they're getting ready to start the phase 2 study, hopefully in the second quarter or the third quarter of this year. There's another company called A-beta. A-beta works on a different type of cells called the T regulatory cells. So all of us have these regulatory T cells that dampens down the amount of inflammation. And we generally believe that one of the mechanisms of IBM is a loss of these T regulatory cells. It's something similar happens in ALS. So there are strategies that have been looked at for increasing the amount of T regulatory cells. So A-beta is actually doing that right now. And the two diseases they are targeting are multiple sclerosis and IBM. So you probably will hear more about it. One of the things that we are trying to do with them is to do a detailed MRI analysis of patients with IBM, which we're trying to bundle that as part of our natural history study. If we can get funding for it, we will probably do about 20 patient study within the Inspire IBM to look at MRI distribution of muscle, because we want to use that as a biomarker for disease, for drug intervention. Similarly, AppCuro is doing what's called PET scanning. PET scanning are these highly specialized imaging that is done with a radioactive material that can be picked up. And because somebody has developed a ligand for these lymphocytes, AppCuro is using that as an outcome measure for their trial. So there are at least 2 active disease trials and potentially a third one that will be coming within the year or so.
Thank you. We have 2 questions about doing surgery when you have IBM. Is it safe to have back surgery, knee replacement surgery? Will it compromise healing?
So the challenge for knee surgery is because the quadriceps is quite severely affected in IBM, the chances of that surgery to work is small. It's like doing shoulder surgery if you have a weak shoulder. Same thing would happen here. If you have a weak quadriceps, doing a surgery for the knee is probably likely to fail. You have a much higher chance of failure. But again, those are decisions that I don't make. Those are decisions that be done in consultation with a physical therapist and orthopedic surgeon. But generally, we advise against major surgery for the knee if the quadriceps is quite significantly weak.
Did you have any thoughts about someone who has stenosis of the lumbar section?
I mean, again, that needs to be taken independently.
Yes.
If they have really bad stenosis and they have nerve involvement from that, or if they have bladder involvement from that, then it probably needs to be independently treated, irrespective of whether you have IBM or not.
Do you have an opinion on hyperbaric therapy?
I've never been a big fan of hyperbaric therapy. I think it's again something that a lot of community physicians have taken advantage of and made money out of it. Other than burn, where you really need hyperbaric, I'm not sure that there's any role for hyperbaric in general medicine.
When you say to contact congressmen for getting funding for the sirolimus rapamycin study, is there a name of the study to use that the representative would know what to fund?
Well, I mean, again, the challenge is that the NIH budget is a congressional mandate, right? So this year, for instance, the Congress just passed the NIH budget, and it's definitely much lower than what they gave the NIH last year. Okay, the purpose of contacting your Congress, your elected official, is to increase the amount of budget the NIH receives so they can fund more research, especially in rare diseases such as IBM. Okay, so I think it's a general ask for increase, not rather than specific projects. But I can find out the name of the specific grant and I can pass it on along. But I think the recommendation would be generally, if Congress and the president can increase the NIH budget, that will have a windfall effect for muscle diseases and IBM in general.
Please discuss body donation options for IBMers.
So I'm not aware of any organized effort specifically for IBM. I think a lot of medical schools have will body donation programs that benefit neuroscience research as well as specific research. So it may be worthwhile contacting your local or your closest medical school and see what the opportunities they have. But to my knowledge, I'm not aware of anything specific for IBM that specifically targets muscle tissue, etc. Now, I'm still a big believer in muscle biopsies. And what we are doing, at least in our side, is then when we have a diagnostic biopsy on a patient, we take an extra piece with the patient's permission and we send it to Dr. Vialta's lab for additional studies, research studies. Okay, and I'm sure there are other groups like Dr. Tom Lloyd's group or Dr. Greenberg's group are interested in something similar. So you may want to reach out to your local medical school.
Do you have any thoughts on blood flow restricted exercise?
Again, so I know it's being done, and I know that patients were swearing by it as well. The challenge is it's not been studied in a systematic scientific fashion. So I know that there is outfit like locally here in San Diego, and I will be taken to task for not saying enough things positive about it. But my hesitation is I haven't seen the data. I mean, again, there are testimonials that patients present that they are getting better. But again, remember, there are placebo effects and everything. So what I would like to do, and I like to see, is a properly done scientific study where the physicians at least are blinded to the treatment outcome. There is a placebo built in, and then we compare whether the patient truly benefited or not. At this point, it's all anecdotal. There are patients who are getting the treatment, who are paying money to get the treatment, which I think is wrong, because unless you have proven that it works, you shouldn't be charging for it. And it needs to be done in a scientific fashion.
This is a nutrition-based question. What are recommendations for protein intake to support muscle retention with IBM?
I'm sorry, can you repeat the question, Rachel?
Recommendations for protein intake to support muscle retention.
So, I mean, in general, I think it's a muscle losing disease, right? I mean, you progressively lose muscle bulk. And what I normally advocate to my patient is that the last thing they want to do is to go on a diet or do funky things that will make them lose weight. Right? They need to make sure that they are taking enough calories, and I would love it if the calories come from protein. And generally, I ask them to increase the caloric intake by 25%. That because you are losing protein, that means you're losing calories. Unless you offset it by taking more calories, you're going to have a net negative loss. So what I normally tell them is take more calories, and the broad figure that I use is 25%. Now, if in the process you put on a few pounds, that's okay. It's not the end of the world. But we definitely can't afford weight loss, which a lot of patients with advanced IBM experience. They do experience some weight loss.
Thank you. Well, thank you so much, Dr. Mozaffar. We appreciate you participating in today's webinar. I'm sorry to say that is all the time we have. If we did not get a chance to answer your question, we will submit it automatically for our next Ask the Doc series webinar, which airs on Thursday, April 21st from 6 p.m. to 7 p.m. EST with dermatologist Dr. Victoria Worth. Hope to see you then. Thanks again, Dr. Mozaffar. We appreciate you.
Thank you.
Bye.